Did you see that nominations for the podcast awards are now open? DNA Today won 3 years in a row, but we lost last year. So we got to step it up to reclaim our title as the best science and medicine podcast. How can you help us do this? Head over to podcastawards.com, click the blue button that says nominations voting, and fill out your info. Then here's a critical step. Check off that first box that indicates you're open to being randomly selected as a voter in August. This is key. We need some of you listeners to be in this pool for final voting. Once you submit this, you will immediately have access to the nominations page. Scroll down to the Science and Medicine category and select DNA Today. Then hit Save Nominations at the bottom of the page. That's it. We're so grateful to have such an incredible listener base, including you. We have been up against popular podcasts with huge production companies, and we will again this year, which is why, as a small independent podcast, we rely on each and every one of you to get nominated and hopefully win again. It is the People's Choice Awards after all, so we need you, our people, to support us. So again, please go to podcastawards.com, fill out your info, select DNA Today in the Science and Medicine category. Pause the show now. I swear it takes 30 seconds to do it. I timed it for you. Again, podcastawards.com, DNA Today in the Science and Medicine category. Thank you oh so much.
How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, the genes of you and me, we're all made of DNA. We're all made of the same chemical DNA. We're all made of DNA.
Hi, you're listening to DNA Today, a multi-award-winning podcast and radio show where we discover new advances in the world of genetics. From genetic technology like CRISPR to rare diseases to new research. For over a decade, DNA Today has brought you the voices of leaders in genetics in over 200 episodes. For the past 3 years, DNA Today has won the People's Choice Best Science and Medicine Podcast Award. I'm Kira Deneen. I'm a certified genetic counselor and your host.
Welcome to the show. My name is Kristina Inman. I'm a second-year genetic counseling student at Sarah Lawrence College, and I am here today with Dr. John Greally, who is the director of the Center for Epigenomics, professor of genetics and pediatrics, and chief of Division of Computational Genetics at the Albert Einstein College of Medicine and the Children's Hospital at Montefiore in the Bronx. Thank you for being with us today.
Thank you for having me on.
And I know that you have a new initiative, the Nord Center of Excellence and the NY Center for Rare Diseases, and you're co-directing that with Dr. Melissa Wasserstein.
That's correct. It's a new initiative at Montefiore, which recognizes that we just happen to be very good at providing care for patients with rare diseases. We have 30 separate clinics that we found have services for people with rare diseases. And we've become part of the Nord network, and we really want to see if we can do better as regards improving the diagnostics, care, and therapies for these patients.
Great. And I'd like to hear about your experience in the field of rare pediatric conditions and what your latest endeavors are. And I'd also like to know more about how genetic counseling has recently become more intimately relevant to your life. And just a little about us. We're acquainted because you are one of my advisors for my thesis work at Sarah Lawrence College. So thank you so much for that. And again, thank you for being with us today. Why don't you start with your research background?
Well, what I've been, I suppose, building my career on for all these years has been the field of epigenetics. What I realized was that the word epigenetics can mean two different things to two different people. It's quite confusing when people try to use their own definition and apply it to somebody else's area of research. So I've encouraged people to use the word epigenetics, but always explain what they mean when they're using the word. What I've been what I started off being interested in was not called epigenetics at the time. It was a recognition that during the years of the Human Genome Project, we were getting the sense that we were being promised answers to hereditary diseases purely based on the DNA sequence that we would be seeing in different individuals. And if you've ever seen a patient with sickle cell disease, you realize that sickle cell disease is never the same disease twice, even though it's always the same mutation. And therefore, there had to be other sources of variability involved. And while epistatic effects in the genome are certainly where a lot of the action is now recognized to be, I went off on the tangent of trying to understand what information might be in the cell apart from that in the DNA sequence itself.
And that was what sparked your interest in epigenetics?
That's what subsequently became called epigenetics. I was very influenced at an early stage by the work of scientists from the Fred Hutch in Seattle, and he passed away prematurely, a man called Hal Weintraub. And he was writing papers about how DNA did not exist naked in the cell. It was associated with proteins, and he was proposing that those proteins could have some information embedded in them that would help with heritability of information from parent to daughter cells. So I became interested in this field. Started off by looking at genomic imprinting and X chromosome inactivation, and then through a generous gift from the Gottesman family, who have been in the news recently for their extraordinarily generous gift to the medical school here at Einstein, I was able to set up the Center for Epigenomics at Einstein and started to try to understand what was the basis of human disease that could have been mediated by some of these things that we're calling epigenetic, such as DNA methylation and chromatin structure. And that's where I started to have a crisis of faith.
And that's what's leading to you writing a book about that.
Yeah, so I have a book that hopefully will be published in 2025. It's on epigenetics. I've taken a detailed look at the history of the field, going back to antiquity and pre-antiquity, and tried to understand how people developed ideas about fertilization, sex determination, embryogenesis, and how that informed then how we started to think about what was called epigenesis, which was part of the foundation for this field. What I've tried to do in the book is to take a pretty cold-eyed look at some of the beliefs that we have in the field today, with the hope that it will stimulate people to go back and be extremely rigorous with the underpinnings of some of our beliefs that we have, and hopefully improve the quality of the science. For example, one of the things that caused my crisis of faith was I started to realize that when I would take cells from you and from me, and there would be the identical cell type, we would have differences of DNA methylation that had nothing to do with the cells in me being reprogrammed because I had, a different lunch to you or something like that. That in fact, a lot of this variability was due to hidden effects of cell subtype variation between us, and that's a very strong influence on these so-called epigenetic patterns. But even stronger is the influence of DNA sequence variation between the two of us. It really looks as if that's a major driver of these changes that we would otherwise ascribe to cellular reprogramming. But I've tried to turn that to our advantage and have made the study of functional non-coding variants in the human genome a major area of emphasis of my lab today, and recognizing that it can be read out by some of these assays that we've been using to study the so-called epigenome.
And what is a functional non-coding variant?
We recognize that of the 4 million differences between genomes of any two individuals on planet Earth, that there is a subset of these variants that have influences on the regulation of genes. They're probably located within cis regulatory elements like promoters and enhancers. They probably modify the ability of a transcription factor to bind to the DNA, sometimes decreasing that ability, but work out of the Stamatoianopoulos lab in the University of Washington shows that probably half the time it's increasing the affinity of binding of the transcription factor. And it looks as if these loci of transcription factor binding are inherently polymorphic, that they are more polymorphic than the surrounding regions of the genome. So it's a great source of variability. It's a very interesting set of evolutionary questions that we can ask about these. And what I'm finding is that long-read sequencing technologies are revealing the presence of these functional non-coding variants in ways that we have never been able to perform previously. It's a very exciting field to be in right now.
And I've heard of the term of regulatory landscape. Can you describe that to us, kind of maybe at like a middle school or a high school level, just to put this all into context?
The regulatory landscape is a description used for the genome that recognizes that only 3% of the genome is actually genes, and the rest of the genome is doing something else. What it is using that 97% for is to encode the pieces of DNA that will allow the gene to be switched on or off, or upregulated or downregulated in a way that is appropriate for a specific cell type or tissue type and a stage of development. And if you were to look at what is lighting up as in a neuron versus a keratinocyte of your skin versus a hepatocyte in your liver, you'll find that different areas of the genome are being used in those different cell types. Geographically, you'd see different features on that landscape compared with another landscape. The genome can shift in terms of its properties from cell type to cell type. But what I'm particularly interested in is the polymorphism that would exist between two individuals for their regulatory landscapes. This appears to be a major source of variability and is probably what genome-wide association studies have pointed us to as the reason for different people having different susceptibilities to common diseases.
Great. And what's the most recent study that you're doing on that right now?
Well, we have some very interesting data emerging from reanalysis of the whole genome sequencing data that has been performed by the Simons Foundation and the Autism Speaks Foundation, looking at individuals with neurodivergent traits and some of whom have low IQ, and compared with neurotypical individuals. I have no interest whatsoever in pathologizing a trait. I have no interest in having a diagnostic test for autism when you have nothing else going on with you. And what we're finding, which is kind of reassuring, is that the biggest differences that we have between the individuals with autism and the neurotypical individuals are actually reserved for the individuals who have low IQ, which appears to be driving most of the differences. And that's actually quite satisfying, because that's what the families who come to my clinic are looking for. I see quite frequently that they're not interested in doing genetic testing if their child or family member is neurodivergent but is doing pretty well at school, and that's just personality. But if the child is struggling, if they have concerns about how that child is going to do after they as parents pass away, those are real issues to address in a clinical setting. And that's where I'm glad we're able to focus our efforts to understand how much of the variation that occurs in the non-coding genome in this regulatory landscape could be contributing to those kids' problems.
You mentioned pathologizing traits, and I want to go back to epigenetics a little bit. That's been something that we've seen in the news for the past decade or so, people hypothesizing what it could mean for us clinically, what it could mean at a population level. How are we able to study epigenetics in a meaningful way? And I was curious about your thoughts on how the study of epigenetics is portrayed in the media.
Well, it's a vastly optimistic picture, over-optimistic picture, I think, in terms of this idea in particular that your genes are not your destiny and the epigenome is plastic, and if you go in with an intervention, you can overcome whatever genetic predisposition you might have to a disease. I always joke that this is the reason why people eat kale, that there's something about the ability to reprogram your genes that's in some way going to be healthy for you. And that's certainly possible. I have to say, though, that the evidence to support that a major influence for these interventions on your health is weak. And we are probably better off using DNA methylation of peripheral blood as a biomarker that can be used as part of health maintenance. And it seems to be working extraordinarily well in certain ways. There was a study out of UCLA where they did DNA methylation studies on peripheral blood of individuals that were in their health system. They also had genotypic information, so they were able to look and see what sort of predictions you could get from the DNA methylation information compared with polygenic risk scores in the same individuals. And what they were finding was that the DNA methylation information appeared to be outperforming the polygenic risk scores, which is probably because DNA methylation is influenced by sequence variability, but is then also influenced by things like cell subtype alterations in the peripheral blood.
Mm-hmm.
So it's perhaps capturing more information that is relevant to people's diseases. This is an early stage of investigation for the field. I would love to see confirmatory studies, but certainly as a biomarker, there's potential for these kinds of assays to be used in human health.
Great. So 2 different areas where we're sort of going a little bit deeper and looking for implications for public health on a wider field.
Exactly. And it's a really interesting era to be doing research in genomics and science in general, I suppose, because we have all of these powerful machine learning tools that are now being applied to data sets that we would previously not have seen much extra value in. We have for example, people are looking at fundoscopy of the eye, and they're able to tell whether I'm not sure how they define male and female, but they have male-female categorization. They're able to tell whether you have diabetes. There's even the ability with radiology imaging these days to determine your continental ancestry, which is quite interesting because it suggests that if you have AI-based approaches for that are meant to enhance your ability to do diagnostics and imaging, that if there's a large influence of race and ethnicity on those images to start with, you better be modeling correctly so that the studies can work for everybody.
Mm-hmm.
What we are doing is we were working with Google, the Google research team, including their DeepMind colleagues, to see if we can build a machine learning model that will allow us to identify functional non-coding variants in the human genome, basically the equivalent of alpha missense, which the same team also developed, but for functional non-coding variants. And if we are able to identify those with a reasonable degree of certainty, that could be very important diagnostically and in understanding the basis of many complex and rare human diseases.
Okay. And if I'm understanding this correctly, the functional non-coding variants are a little bit harder to study because they're not having the most upfront functional effect on people. There's massive amounts of data to even apply this affecting health. And so you're saying you want to try to find a way to implement machine learning, AI, to sort of sift through that and find what is actually contributing to our health.
I think if we compare it with the information that's encoded in the coding part of the genome, we understand those rules. What we don't understand is the rules of how promoters and enhancers and silencers and insulators, how DNA sequence changes at those loci can influence their function. And we also, for many of these regulatory loci in the genome, don't even know which genes they regulate, because they may be regulating the nearest gene, they may be regulating 2 genes over.
Wow.
So the knowledge gap that is between our interpretability of the coding genome and the interpretability of the non-coding genome is pretty vast at the moment. So any tools that allow us to start narrowing in on what appear to be functional non-coding variants could potentially be extremely useful, because we can add them to the diagnostic picture when we're trying to understand human diseases.
Mm-hmm. That's really interesting. Now, that leads me to asking a little bit about something I'm more familiar with that also uses a little bit of machine learning. Would you like to tell us a little bit about Genome Diver?
So the Genome Diver software that we developed as part of the CSER consortium, we were the NYC KidSeek site within that, is software that's designed to facilitate communication between clinicians who are seeing the patients and the diagnostic lab that is trying to interpret the DNA sequence. And what we're really aware of in diagnostics, genomic diagnostics, is that we're not communicating a lot of information about what the patient looks like in a way that's effective for the laboratory to be able to use the information diagnostically. Because the reality of what a lab is looking at when they look at a patient's genome is multiple damaged genes. And there can be several genes that are duking it out to be the top gene associated with the individual's rare disease. But if you know that in one of the associated conditions, there is microcephaly, a abnormally small size to the head. And in another patient, there could be a cataract in one or both eyes. And if you haven't told the lab that, and they're trying to decide between those two genes that can be distinguished, distinguished based on those phenotypic differences. That's an awfully it's an awful waste of an opportunity, and we don't have good mechanisms for that. So with Genome Diver, what we do is we use the genetic information about a patient before the lab is locked in on the diagnosis. We allow it to prioritize certain variants and genes, and those variants and genes are associated with diseases, and those diseases can be described in terms of phenotypic terms from the human phenotype ontology that can then be used to be put in front of the clinician to ask them, does the patient have this? And you can drag and drop and say, definitely the patient does have this or does not have this, or for many of them, you really won't know. Mm-hmm. And if we can then have the physician package that up, send it back to the lab, just think of how much more information the lab then has to use diagnostically. So we're building this as a kind of a decision support tool that can facilitate the clinicians seeing the patients, have them use it very efficiently so that it doesn't take much time, that it's intuitive, and ultimately will aid in the diagnostic process.
Mm-hmm. So the underlying message through a lot of these endeavors is that there's a lot of information that we could be using, but trying to find a way to actually incorporate it into patient care or to use it for the purpose of genomics. We need some help, and we're trying to find ways to do that through technology.
Absolutely, yes.
Yeah. I'd like to talk to you about something that happened to you last year. You have been in the field of taking care of other people for a long time. You've been taking care of children with a number of conditions, and you've known their families, you've walked their parents through what's going on, you have dealt with their siblings and all of the implications, basically the whole wraparound care for these families, and you've seen a lot of different conditions come through the door, and you know a lot about them and the lived experience. Tell me a little bit more about how this became personally relevant to you recently.
Yeah, it was irony upon irony. So on July 6th of 2023, I went in for an echocardiogram, not for the most rigorous of reasons. There was a family member who had a concern, which ended up being nothing. And because I have good health care, because I have access, because I'm, very privileged overall, I was able to get an echocardiogram so I could set my mind at ease that I didn't have anything related. And instead, I was diagnosed with a congenital malformation of my heart that, as it turns out, was causing me to walk around with a 6% annual risk of sudden death. So it was a pretty easy decision that I should have open heart surgery 12 days later on July the 18th, which I am glad to say was completely curative. And I am now watching it recede in the rear view mirror. But you're aware, because we've talked about this, but you're aware of the fact that my encounters with patients subsequently were much more emotional. I, instead of being the guy with good health, everything going for him in life, all of a sudden I was talking to them about the possibility of their family member having something which was genetic, something that was was not going to go away, something that could have serious health effects for them. And I started feeling it a lot more. I started to see the pain in their eyes, the fear in their eyes, in a way that I'd never really experienced previously. So it's been more difficult to just carry out my clinical duties. It takes more out of me. But I'm regarding this as a positive experience in that it's really teaching me empathy in a way that I've not been able to experience previously. And I've also been a consumer now of genetic testing. I had testing done for the kinds of genes that could cause the type of congenital heart disease that I have. And I am now not a fan of variants of uncertain significance from both a provider and a patient point of view.
Mm-hmm. Yeah. You have a new appreciation for the complications of a VUS.
I have a new appreciation for how I believe VUSs should never be reported.
That's very interesting. That's probably an entire topic that we could dive into too.
Mm-hmm.
I imagine it was a shock to find out that you had something underlying, especially since you'd gone in for an unrelated medical issue. When did it strike you that you use the word irony, that this was something affecting you, and someone who knows well what these implications could mean? What was that like?
It's a real challenge to regard yourself as inherently flawed. I have not been able to think of myself as this kind of invulnerable individual in good health since that episode. You're so lucky when you walk through life, and the worst that happens to you is that your knees get a bit more sore as you go running as the years go by, or whatever it might be. But to feel like you've got a fundamental problem that you were born with, and you never had a normal heartbeat until the surgeons patched everything up for you, that's a strange feeling. That really undermines your sense of your own, as I say, invulnerability. You now feel that you have a flaw, you have an inherent problem. I'm very lucky in that my problem was completely fixable, and all the follow-up testing I've had has been great. But it does leave you feeling like the floor isn't quite as solid under your feet anymore.
And even though you feel like maybe your self-image, when you look in the mirror, maybe you feel like, oh, I see myself a little bit differently. Has the positive of that been that you feel more motivated or more connected with your patients and the population you're treating?
Absolutely. And actually, the other thing that it has led me to believe in is that we need to do a much better job of using genomics in clinical care. So while my genetic testing gave me a VUS, there are many people that if we were to study the population that we could find had this risk of a congenital heart problem, as well as many other issues that we'd be able to use if we were to apply genomic testing more widely. Now, I am very, very conscious working here in the Bronx that not everybody's going to be comfortable having their genome sequenced. Not everybody's going to be comfortable with getting all of the information back that you can use your genome sequence for. People are going to be uncomfortable about the possibility that they could be discriminated against even more than they are here in the Bronx, that because of this additional information that they are providing. But at the same time, I believe that we should be using as much information as possible to help our patients. I abhor the fact that as a field, we have systematically excluded everybody who doesn't look like me, not Northern European white. And the Bronx is a great place for us to try to address some of these issues of sensitivities and rebalancing the provision of medical genomics and genomics research to populations that have been excluded. So I'm very motivated to take my own experience and to try to use the emotions that have come from it in a very positive way.
I also had a unexpected diagnosis later in life of not something quite as serious as what you experienced, but I realized that I had celiac disease, and it changed my self-image. It changed how I feel in terms of awareness and advocacy in medical care, and just what kind of experience we have going to the doctor, the diagnostic odyssey, what kind of responses we're getting when we have a complaint. And it inspired in me a thought of, if I'm going through this, a white woman, and I have enough access to medical care, and I still didn't get a diagnosis until I was in my 30s, I've had lasting effects from it. It did show me another side of what is this like for people who don't have all of these privileges I can take advantage of, or the access that I have, or just simply providers who believe what I'm saying to some extent and they don't write me off. And I had a lot of fire lit under me for that effect. And it does change your ability to empathize a little bit, kind of just opens your eyes to the possibilities. If this could happen to you, then it's even more likely to happen to others.
I think you're expressing very much the emotions that I've been going through myself. Celiac disease is quite a common condition in Ireland, where I'm from, with the result that a lot of my friends who have celiac disease in the United States, when they go to Ireland, they go to the west of Ireland, my hometown of Galway, they're delighted that there's so many gluten-free options for them. And it's
Well, that's
just
great to know.
And there are many other reasons to go to Galway as well. But the process of going through a frustrating diagnostic odyssey is obviously something that our rare disease patients have to endure. You've had to go through it yourself, and this stuff doesn't go away. You're still left with concerns about your health, even if you're managing things well. And this is good for empathy, and for everybody to be able to explore where they could tap into these wells of empathy that exist in all of us is going to be, I think, a very useful thing, especially in healthcare.
Along those lines, I'm becoming a genetic counselor, and this is one of the things we touch on a lot in our training. For people who have lived experiences, we have that lens, but we also try to put ourselves in shoes of people who have lived experiences that aren't the same as ours. And it's something that we really dive deeply into. I know you have an appreciation for genetic counselors, and you work with several, and you've been wonderful in being a mentor for us to work on our theses through Sarah Lawrence College. I'm curious if you have any thoughts or wisdom to impart for genetic counseling students, future genetic counselors, or people working in the genomics field.
I have a niece, my brother's daughter, who would dearly like to become a genetic counselor herself. That's about as positive a buy-in as my family is able to demonstrate. Genetic counseling is an amazing resource to be able to offer to patients. It's people who are expert in a domain, who are also, I think, very consistently and well trained in empathy and the kind of psychological issues that have to do with imparting difficult, challenging information to families. Having said that, I think that the way that we provide genetics in medicine is going to change radically, not just for physicians like myself, but for genetic counselors and for all of our colleagues as well. The fact that we can sequence a human genome now for $99 at the Broad Institute or whatever it might be means that there's a likely offering that's going to pop up at the end of the year for people who have a bit of money left in their health savings account, where they may decide to buy a fancy new pair of glasses or get their genome sequenced, and the price point is going to be about the same. So why would you get your genome sequenced as opposed to getting a nice new pair of glasses? And to me, it's all about what value would the genomic sequence be versus what's the risk involved. And this is where I see a huge problem with health systems and our preparedness for this deluge of genomic information, which is almost certainly going to hit us pretty soon. Now, we cannot scale genetic counselors and geneticists to meet this impending demand, and this demand is going to come. So we have to think in terms of how do we use our resources in a way that can serve as many people as effectively as possible. So I would see there being a role for electronic means of communication and something which is very scalable to address the majority of tests that come back as negative, while we focus ourselves on the individuals in which we get positive test results. And right now, that is not the way that we do business. Everybody gets the same care from us, the same feedback, whether they get a positive, negative, or ambiguous result. And I don't think we're going to be able to do that in the future. So I would see some major challenges for all of us in this field where we're trying to offer support for our patients, whether it's genetic counselors, clinicians, other advanced practice providers who are now getting into the field, and colleagues who are going to be as obstetrician gynecologists, as nephrologists, as pulmonologists. They're going to start getting genetic test results informing them about their patients as well.
Mm-hmm.
How do we distribute this load? It's going to be a massive challenge, and I think we're all going to have to be very adaptable in terms of thinking of creative solutions.
Mm-hmm. And nowadays, there's a few different avenues through which people are getting genetic testing done and getting those results delivered to them. You didn't mention this specifically, but perhaps implied it. Direct-to-consumer testing is increasing in demand. There's lots of different companies with very diverse offerings. Some a little bit more sound than others, some with clinical importance and some with more of a, some people will call it recreational testing. I agree with you in that we need to find a way to deliver the services that a genetic counselor is capable of. But the question is how, especially with the increase in demand from every angle.
Exactly. Honestly, I struggle to see how a direct-to-consumer model is going to be successful in this day and age when the challenges for our clinical colleagues to be able to digest this information is difficult enough. But if you impose that burden instead on members of the public who have no scientific or medical training, you're really putting a huge weight on their shoulders. And we know that this information is potentially harmful and damaging. It's non-trivial. So I don't think that there is a good model for direct consumer genetics that, apart from, fluffy things like your ancestry. What I do think we have to address is how to implement genetic testing at scale in health systems so that it can be part of the clinician's workflow, embedded within electronic health record systems, and serving digestible information that can be used in the patient's care.
And I know a lot of the projects that you're working on are sort of trying to address those things, trying to digest all of the possible results from something like whole exome sequencing. And then the clinician is stuck thinking, well, what do I do with this information?
We still are doing very, very poorly in diagnosing rare diseases in terms of genomic testing. So even when we sequence the entire genome, we get, relatively low diagnostic rates. What I'm always struck by is if I'm talking to my colleagues in, say, Seattle Children's or UCSF or Cincinnati, and they talk about exactly the same testing that we would be using, say exome sequencing, for exactly the same indication, like perhaps seizure disorder. They talk about diagnostic rates that are way above what we are getting here in the Bronx. And our diagnostic rates, I would say, are probably half to 2/3 of the rates that I'm hearing from colleagues elsewhere. And I think, I don't have evidence for this, but I think the difference is that 91% of the residents of the Bronx are other than Northern European white in their genetic ancestry. Mm-hmm. And I don't think that we have great insights into the potholes in the roads that are not the Northern European white roads. Mm-hmm. The genomes that we see are large, have a huge amount of sub-Saharan African and indigenous ancestry. Mm-hmm. There's quite a bit of Asian representation in the Bronx as well, especially South Asians. We have Middle Eastern groups as well. And these genomes are just less well studied. And my feeling is that we need to get better at understanding what the variation is in these genomes before we're able to start getting the rare disease diagnostic rates up to a parity with what my colleagues are seeing in health systems where they're largely serving Northern European white clientele. we've been fortunate in developing a partnership through the New York Center for Rare Diseases with 3 commercial entities who are all really extending themselves to try to do some good here in the Bronx. The 3 companies are the diagnostic company GeneDx, the DNA sequencing technology PacBio, who do the long-read sequencing technology, and Google. Google Health have been a wonderful partner as well. And what we hope we'll be able to do is to use pan-genomes that represent the diversity of the world's population with these long-read sequences and see if that helps us to improve the diagnostic rates in the underrepresented genomes that comprise the people of the Bronx.
It sounds like you're being very mindful to the people who are here and trying to find answers for anyone of any background. You've had another number of talks where you point out the need and the very deep and historical issues that are facing the population. And I appreciate that that's an element that you incorporate. I'd also like to know a little bit about the principles for genomic privacy sharing.
Yeah, so the World Health Organization, the WHO, they have been interested in the vacuum that exists to guide member states, 194 member states, about what they should be doing with genomic data privacy and genomic data sharing. So they invited me and one other person from the United States, although she may not refer to it as the United States, Crystal Sosi, who's Indigenous American. Anyway, we were the 2 people who were brought over to Geneva to talk about this. There were Canadians, there were people from Sub-Saharan Africa, the Middle East, South and East Asia, Southeast Asia, Australia. So it was a really international group. We were tasked with coming up with a set of principles for how genomic data should be maintained as private and should be shared usefully for discovery. And these 2 things are potentially in conflict. And, different people will have different levels of comfort with the idea that they can share their genomic data. In one of the conversations I had with a Bronx community representative group, I gave my pitch saying that I wanted to make sure that we were serving all communities and not just white Northern Europeans in the world of medical genetics. And at the end of my talk, an older Black woman put up her hand and she said, "So let me get this straight. You want to target us?" And I said, I wouldn't use the verb target, but yes, I want to make sure that all communities are represented. And she said, "And then you'll have information you can use to kill us." So I wasn't going to try to roll back hundreds of years of racism in a response and, plead that I'm a nice guy and I would never be using anybody's genomic information to kill them. That was not a productive avenue to go down. But in talking to her, I learned a lot. And what I learned is that trust is very, very difficult to gain in these kinds of situations, because especially when the data are very complex. So control trumps trust. If somebody gives their genomic information and they can control how it's used, then they're much more comfortable, whatever your background, whatever your racial, ethnic, demographic group, everybody who has any concerns at all is going to be much happier with the idea that their data will be used responsibly if they're in charge of it. So I went to the meeting in Geneva with these words resonating in my brain, and the discussion, I think, was very much about trust. And I said, can we talk about control and how we want to give people agency over the use of their data? The only problem with that discussion was that for a lot of the people from different language groups around the world, agency does not actually translate in any way. There's no equivalent word. So the wordsmithing that was involved in creating this document was very impressive to me. A lot of people with legal and ethical training who really think deeply about the resonance of each word that is used in these kinds of documents. But I'm very happy that it was a very thoughtful group, very interested in doing the right thing by people in all of the United Nations member states. And the document, I think, reflects to some extent the viewpoints of folks in the Bronx. And actually this evening, at the time of recording, I'm going to be jumping on a call with about 50 community representatives on a Zoom call organized by a wonderful colleague, Paulette Spencer from the Bronx Community Health Network. And what we're going to do is we're going to go through the document, and people can ask questions, can raise concerns, and everyone will be encouraged to write their own responses to the WHO and submit them to our colleagues in Geneva. So the voice of the Bronx will be heard in the World Health Organization in terms of how the genomic data should be shared and made private. And I'm delighted that these wonderful people who live here in the Bronx will have that voice.
I think that's a great note to end on. It gives something for people to go look for and get involved in, and we'll put some info in the show notes. Thank you so much for telling us about what you're doing here in the Bronx and your personal take on this close experience to genetic counseling and genomics that you now have, and all of the wisdom that has imparted to you.
And Tina, you're graduating shortly at the time that we're recording this. I wish you all the best in what I'm imagining is going to be a very successful career.
Thank you so much.
For more information about today's episode, visit DNAtoday.com, where you can also stream all 200 plus episodes of the show, including video versions of interviews recorded in 2021 or later. Any questions, episode ideas, guest pitches, or sponsor inquiries can be sent into info@DNAtoday.com. Be sure to follow us on social media, especially so you don't miss a giveaway. We are at DNA Today Podcast on Twitter, Instagram, LinkedIn, Facebook, and more. Please rate and review the podcast on Apple, Spotify, or wherever you listen. This truly helps us climb the charts and allow more genetic nerds like yourself to find the show. Here's a bonus. If you do and send us a screenshot, I'll give you a shout out on the show. DNA Today is created, hosted, and produced by myself, Kira Deneen. Our team includes communications lead, Corinne Merlino, video lead, Amanda Andrioli, outreach intern, Sonia Tanaiker, social media intern, Kajal Patel, and graphic designer, Ashlyn Anokian. Thanks for listening, and join us next time to discover new advances in the world of genetics.
The genes of you and me, the genes of you and me are all made of DNA. We're all made of the same chemical DNA. We're all made of